Well, anti-VEGF therapy is very effective in DME, but it's not effective in every patient. And we don't really know until we try it. But basically where it's very effective for wet macular degeneration, there are a few patients that don't respond. In diabetes, there's probably about a 50 to 60% good response rate, but somewhere between 30 and 50, somewhere in that range, a third to a half of patients don't respond. We don't know why up front. When we start treating a patient, we don't know which will be a good responder, which won't. But that is the main limitation. It works very well in some, but not all patients. One of the advantages of steroids is that they work in essentially every patient. There's relatively few steroid failures, and again, most of our experience these days is with the dexamethasone implant, the so-called Ozurdex implant, and the response rates are very good. The major downside, of course, are the ocular complications, the ocular side effects, shall we say, of steroids, which is true of all steroids to varying degrees, and that's causing cataracts and raising intraocular pressure. So we try to avoid, that's why there's a hesitance sometimes to use them because of those side effects. Though with, again, the Dex implant versus the other steroids, the intraocular pressure management is very easy. And the cataracts are a problem, but the good news is that it really, if cataract surgery causes inflammation, but when you have the Dex implant in place, it really controls that inflammation and the macular edema. It depends on payers and other issues, but by and large, I think if somebody is pseudophakic, they've already had cataract surgery, that's a patient to consider it very early on, maybe as first-line therapy because of the ubiquitousness of the response. Essentially, all patients will respond to it. But certainly, if you've injected anti-VEGF 3 times on a monthly basis and the response has been suboptimal, there's a variety of studies that have shown that it's probably not going to get any better over time. So that would be the time to consider switching. You started with anti-VEGF 3 injections. If you're not happy with the response, consider using the Dex implant. There's not a lot of head-to-head clinical trials or clinical trials to justify switching, so a lot of it is inferential data. We know that VEGF levels are very high in patients with DME, but we know that the other inflammatory cytokines mount up over time. So patients that have more long-standing DME seem to be the candidates that respond worst to anti-VEGF and respond to steroids early and late. So what we have are a lot of real-world studies in patients that have both treatment-naive and refractory to anti-VEGF therapy, and they typically show a very good response to Dex implant. Finally, there was a meta-analysis done of almost 4,000 patients that had been on therapy for anti-VEGF, had been on therapy with anti-VEGF agents for DME that had a suboptimal response, and then they were treated with either Dex implant or anti-VEGF therapy, and essentially every one of those studies favored the use of Dex implant over anti-VEGF if those patients have had a suboptimal response to anti-VEGF.